Independent consultant working at the intersection of AI, pharma, and medical devices. Mr. Saurav Bhattacharjee.
One thing in all these years that I learned as in medical transcription is that
I suspect the person leading 500 plus members team today was shaped in that chair more than anywhere else.
discipline and attentiveness are two frontal pillars of leadership.
Hello, everyone, and welcome to FaceTime with Leaders, powered by Directors Institute, World Council of Directors. I'm your host, Sunny Pancholi. Today's conversation is about something most of us take for granted: the safety of medicines we swallow, the devices that keep our loved ones alive in hospitals, and the quiet systems that make sure nothing goes wrong between a factory floor and a patient's bedside. Behind all of that work sit people we rarely meet. Our guest today has spent over 16 years inside that world. He has led teams of 500 plus in medical devices, driven quality numbers from 40% to 90%, and now consulting independently, helping companies bring AI into pharma and device operations. So please join me in welcoming Mr. Saurav Bhattacharjee, Senior Project Manager, PMP-certified, former drug scientist at IQVIA, former Associate Progress Project Manager at Wipro, and now an independent consultant working at the intersection of AI, pharma, and medical devices. Mr. Saurav, thank you so much for being here today.
I feel privileged to be there here today. Thank you.
So, looking forward to a great conversation ahead. Let's dive right in now. Mr. Saurav, tell me, something about your career really stood out to me when I was preparing for this conversation. You started as a medical transcriptionist, sitting with a headset, listening to doctor after doctor dictating notes about real patients. And you did that work for nearly 9 years before anything else. And I find that genuinely interesting. So, my question is, what did those quiet years actually give you? Because I suspect the person leading 500 plus members team today was shaped in that chair more than anywhere else.
Yeah, thank you. Basically, I started my career in medical transcription. Medical transcription, many people might not know what exactly it is. It is listening to doctor's transcription with the help of headsets, understanding the grammatical part, the English part, and also the medical English. Medical English. All these three things put together. When the doctor dictates, we have to transcribe it, and this transcription generally has to be done in 8 hours. The number of lines, the more the number of lines, the better. I started initially as a trainee transcriptionist. Initially, we started at very less words because we were up to the end of our training. We are supposed to go up to 100 words per minute typing so that we can reach the optimum level. So first 3 months were our on-job training, where we were doing around 20 to 40 words per minute with our headset. This basically taught me the discipline and the attentiveness which is required in medical transcription. Sitting with the headset, understanding the doctor's transcription, there was no scope for mistake. There was just no scope for mistake. The doctor was transcribing it. As we know, in US, the doctors are very busy. They don't have time for doing mundane works like transcription and all. So they give it off to third parties or to they outsource it. But the one thing for them is very clear. We have to have 99.5% accuracy. There cannot be any misjudgment in accuracy there, because that 99.5% is a patient's life. In fact, it is 100%. You cannot have any misjudgment with patient life. Even if you miss a small drug dosage there, the patient can die. So this helped me a lot to understand and be attentive and also be disciplined. discipline and be attentive, because without this you cannot do transcription. For 8 hours you have to constantly sit and listen and type. As I moved forward, I became the full-time employee. I interacted more with doctors and learned how these doctors work. In US, the doctors literally, in India, sometimes doctors make a mistake, but in US there is no scope for making mistake. The doctors cannot make mistake, and they expect the downline for them also they should not make mistakes. So I understood how stressed they are, but how caregiving they are, that how they literally means helping patients' lives, changing a patient's care, understand, and in that way what goodwill they earn, And as regards to the patients in US, the patients, of course, they expect the doctors to be the best out there. They have to give them care. They have to help them. And of course, one more thing which is very important is that they are very much particular about their medical records, which have to be confidential. You cannot allow their medical records to get into anywhere, which can lead to serious issues. For that reason, both the doctors, the patients, and of course us have to sign the HIPAA Act, in which the confidentiality of the patient needs to be maintained. The patient expects good caregiving, but the patient also expects that the caregiving is done in a means it's not a very costly manner. In a not cheaper sense. I mean, quality should be good, but it should be in a you can say it is in a cheaper sense only, in a far cheaper sense, so that they don't always have to rely on their own resources to pay the bill. In that way, us transcriptionists, we were the go-between between the patient and the doctor, and it's a fact, of course, that the quality has to be paramount. 99.5%, though the doctor says it is not, it is 100%. The patient has to have a 100%. Means 100% accuracy here. You cannot miss anything related to the patient. One thing in all these years that I learned as in medical transcription is the discipline and attentiveness, which helped me in my leadership goal. Discipline and attentiveness are two frontal pillars of leadership. First, you have the discipline, where you have learned focus, where you learn resilience. With focus, resilience, you can understand and help your team out. You can understand the problem of your team. And of course, then comes attentiveness. Attentiveness, of course, is another part of discipline only. Attentiveness comes with discipline. As you get into become attentive, your emotional quotient becomes more valuable for you. You understand the teams more with empathy, understand them better, and help you to deal with the problems. You get a strategic clarity. You start getting a strategic clarity in them, and then you also have that emotional part. With empathy, you understand the team, and then help you to make decisions much more better. These are the things which really help me in medical transcription. And of course, thing is that as I moved on from being a medical transcriptionist to QA, I learned a lot of nuances about this leadership, being in the trenches, starting from below. I started slowly developing my leadership skills, getting into various situations, various positions. I understood that how I can deal with different departments, different people, etc. For me, as I moved from the trenches to the leadership role, I understood the nuances, empathy, everything. And then as I moved to the leadership role, all these things came to be my part. People who do not work in the trenches, they always feel that something like it is a systemic bottleneck can be taken as associate incompetence. People who have not worked in the trenches, they feel that a systemic bottleneck can come as a employee incompetence. People who, for them, they always look at the smaller picture to get the work done, which in reality was not actually done immediately, which in reality took many more painful steps to get the whole thing done. Then then of course that the inculcation of discipline in leadership, then this attentiveness, then empathy, all these things put together help me to understand far better the how a leader thinks in terms of managing, not leading, in terms of managing and not leading. That's all I will say.
So, what a great start to this conversation, Mr. Saurav. And that is something we don't hear often from senior leaders, that the most important skill came from the role no one celebrated. And honestly, the way you talk about it, I can tell you still respect that younger version of yourself. And that matters a lot.
Yeah, yes, certainly. Certainly that was those were the formative years. Those were the formative years where you feel that where you felt there were a lot of uh, fights. There were a lot of trench fights. You can say there were a lot of trench fights, fighting with one person, another person. I want to do more work. I want to, why this person has been allocated this, why we have been allocated this, all these things put together. And I never used to think about at that time how the leadership used to deal with it. I used to think that, yes, this was me first. This was me first. And that perspective, as I moved in the ladder, that perspective changed. That how I used to feel that the leaders were towards me biased towards me. But as I move forward, I realized that this is the way leaders have to take into many, with different types of people, with different culture, different background, and different aspects. Leaders have to understand that one thing will not fit for everybody. You have to have different fittings for different people. So in this way, I felt I developed my leadership skills, and then I went into the next phase.
Great. So, Mr. Saurav, let's get into the work itself, because most of our listeners have probably never heard of the word pharmacovigilance, and that is part of the problem. This is an industry that protects millions of people every single day, and almost nobody knows it exists. So let me ask you, at IQVIA, you were handling 60 to 90 individual case safety reports every month. Reports of something going wrong with a medicine somewhere in the world. Now, for someone listening who has never seen of these files or never heard of these files, can you walk us through what actually lands on your desk and what you are really looking for when you open it?
So basically, it is not only drug, it is vaccine also. So pharmacovigilance involves both vaccine and drug. I think in terms of vaccine, you must have heard recently during COVID, how different vaccines had their different side effects, resulting in immediate death, etc., etc. All these things, because in case of COVID, the vaccines had to be pushed through very fast. A proper pharmacovigilance mechanism was not put in place to check the signals in the sense that what side effects were there, because of which might be in some cases signals were missed, and which resulted in death in many of the vaccines worldwide. And also still now we will find litigation going on in UK, US regarding the side effects of these vaccines. Anyway, coming back to pharmacovigilance, basically there are four things in here. The patient, you will have to check when you open a ICSR, individual case safety report is an ICSR, which we see for the adverse event. First thing is we check for the patient, whether there is a valid patient. Second thing is that we check for the drug, whether there is a valid drug for that particular company for whom we are doing it. Then there is a adverse event. It can be serious, non-serious. So there is whether there is an adverse event, which is a valid adverse event, and then there is a valid reporter in that. So first thing is the valid patient ID, patient, everything should be there. Valid drug, the drug or vaccine, whatever comes there. So whether it is a valid drug, valid drug, we check it. Then comes the adverse event. It can be serious, non-serious, and then reporting. The reporting part will be done by any reporting part can be done by anyone. Like first it can be done by the patient himself or any of patient's caregiver. Second thing, it is a healthcare professional, which involves a pharmacist, a doctor, a dentist, a nurse, or any other person who is designated as a regular healthcare professional. Third is that the reports can be sourced from social media or literature, where there can be different ways where we source from social media and literature. So these are the ways the reporters report. In terms of adverse event, when the adverse event comes, the first thing we need to check is whether the adverse event is serious or non-serious. If it is a serious, it has a different reporting timeline. If it is a non-serious, it has another different reporting timeline. So if it is serious, then a lot of means background check starts. First thing is that serious, what is the seriousness criteria? Whether the person has died or the person has been hospitalized or the person has some medically significant events or the person has developed, or the child or whoever has developed a debility. So these are the criteria which we use. If it is serious, the timeline changes from 7 to up to 7 days. So this seriousness criteria, depending on the seriousness criteria, the reporting also has to be done to the regulatory authorities, and regulatory authorities are very particular about these criteria. If you miss them out, you are going to be in a big soup, especially if it is a death case and you don't report it properly on time. There can be very serious issues. Then this adverse event reporter per drug. Of course, drugs will have to check whether it is a proper company drug or not, whether dosing was provided, or if the generic drug is from some other company, that also needs to be checked. And then the patient, of course, the patient is there in this. Then after the seriousness criteria, the adverse event comes. Then we have to check for causality, whether that event has really occurred because of the drug or not, and then the reporting goes to the regulatory authorities. So this is one part of this ICSR, and of course the regulatory authorities, when they check these ICSRs, they check it for first thing, signal detection. A person has died after taking a drug suddenly by developing shortness of breath. Whether for the same drug, the same issue is getting repeated or not. If this same issue is getting repeated, immediately the regulatory authorities will mark that drug and check whether this issue is one-off or it has been repeated for a long time, and then they will consider pulling the drug from the market. Or maybe even if this issue was a repetitive one and the company or the pharmacovigilance contract provider did not properly document it, then there will be fine on those. Plus, there will be a show cause, and it is a big legal process. Plus, the patients also might end up filing cases, like it is happening in COVID vaccines now, filing cases against the manufacturer of the drug, stating that these are the issues. But the crux here is that it is patient safety. You cannot miss anything. You cannot miss anything here. You just cannot miss anything, because if you miss anything, it is the end user, the patient, who will be the sufferer here. So there can be that secondary causes, can be loss of reputation, everything, but ultimately it is you are helping the patient, so you have to keep that in mind. You cannot just come out of that mold. In terms of the companies will have to, the companies generally will will have to have qualified personnel for this job. They will have to have a risk management a personnel for this job. Then their trainings has to be up to date, and of course their systems has to be up to date with the latest regulation, so that it doesn't get hacked, because you cannot, means patient records cannot go out in the public.
Absolutely. So to sum it up, Mr. Saurav, behind every strip of medicine in a chemist shop, there is somebody like you reading, questioning, and flagging, and that is a layer of healthcare most of us honestly did not know was there, and now we do. We know that. So thank you for enlightening us. Uh, and Mr. Saurav, let's move from pharmacovigilance into medical devices now, because you led a massive program at Wipro with a 500 plus members team. And here's the number that caught my eye. You took quality from 40% to 90%. Now, that is not an improvement, that is a transformation. So when you first walked in and saw the state of things, what was your what was actually broken? And what was the first real move you made?
What was the first real move I made, right? So first real move I made was that I found the root cause. I tried finding the root cause, and then I understood that certain things are really, means initially as the project started, the scope was not clear. The scope was not clear. There was miscommunication between teams, operation team and the technical team. No scope was not clear. The training part for the new recruits was done in a hurried manner. Those three things I found, and found there. The scope was not clear in the sense that when we started in such a suddenly in a huge volume, the requirements were not very clearly spelled out. It was like something like okay, you go and do it, we'll see how it works out. But in case of something like devices, medical devices, where patient safety is involved, you cannot have such layman terms working here. You have to be very clear on what you want. Second thing is that the training, because suddenly we had to onboard 500 plus people, the training was also not given properly, and they were just pushed into the system with a bare minimum training, thinking that all will work, which really shortcut quick fixes really doesn't work. Third thing is the quality part. The quality part was without proper training, of course, the quality went down. So the first step I took here in this case was that the communication between the different teams were improved. The communication started improving. Second thing is that I've created a separate quality team, which in this case, this quality team was very particular about the quality of the cases, and any errors and anything, a direct call up with the concerned associate was done. So this helped in the technical depth part, and of course the training part. Training also, it was realized that the training was not enough. So we again arranged a training with the client for the trainers, and the trainers then again trained the people. So all these things put together slowly improved, and of course the discipline and attention part was also there. When during the go live, two teams suddenly started fighting, saying that this part should have been done by you, this part should have been done by you. So at that particular time, the attentiveness and discipline parts came to the fore. I realized, I just took a pause there, and then I talked with those guys, and then thrashed out a particular solution which was acceptable to both these people. And also I listened to them with empathy, because I realized that in such a charged up situation, you just cannot go for a quick fixes. One more thing I realized was that the quality parts, there was total means lack of feedback in that. That feedback part was taken care in the by the quality team in this quality team, and of course, uh, in one or two cases also we had to let some guys go because we realized that this cannot be means the situation is such that we cannot uh, change their attitude and behavior. The quality then of course the this quality part, one more thing I realized from leadership is that this is not a one-off checkbox. When I initially wanted to create the quality team, I realized that companies are resistant to it because it is a means it is a misnomer for the commercial part or the profit part, because you have to, from your own pocket, you have to add an additional group for just quality, which many companies just don't like because it affects their budget. But I just went ahead and ultimately the work was done well. Initially, there was a lot of resistance to it. The team did not buy in. But as we moved on, as we pushed on because there was no choice. Client also was okay with it. As we pushed on, the team realized the benefits of this. And they decided that yes, this is working better. Cumulatively, the whole thing is working far better, and we started moving from what is that? It was around 40% to 90%. As a senior leader, what I realized here is that quality is paramount, and you cannot connect it with anything else. If you have the quality, you can go to the next level easily. But if you only quick fixes and quantity, which was part there at that time, and which I changed, does not work. Only quick fixes doesn't work. And you should also think about one more thing, is that the KPIs part. You should also learn to ask what it is not showing, what it is showing, not what it is not showing. Whether the client, maybe your KPIs are very fine, but is it what the client wants? Is it what the client wants? Second thing is that that you have to. There are quick fixes on quality, which are done by the lower level people just to keep the overall thing out of your domain. What overall means, keep the quality out of your notice. So that I went into a deep dive. Once we got into the deep dive, we realized where the issues are, and then we took into it. So ultimately, quality is not a one-off checkbox for corporate, but it is overall the system, and that culture and that behavior respect has to be inculcated in the company by the senior management.
Absolutely, Mr. Saurav. 40 to 90 is the kind of number that sounds like a slide in a case study. But listening to you, it is clearly not a slide. It is people, it is coaching, it is patience. And that is the kind of turnaround most organizations claim, but very few actually do. Great. So before we move forward, I would just like to request you that since we are already near to the threshold of time, we'll try to stick upon the major points that you would like to discuss or share with our audiences, and keep it as short as possible, around
Sure.
2 to 3 minutes for every answer, henceforth.
Sure. Thank you.
Yeah. Great. So, Mr. Saurav, here is something I'm personally curious about. You are 16 years into this career. You have PMP, Scrum Master certifications, project management credentials from IBM and Google, and now in 2025-26, you picked up an AI in project management certification. The US FDA has already started evaluating AI tools for pharmacovigilance signal detection. So I want your honest take. What genuinely changes for people in your field over the next 3 years? That is part A of my question. And
First,
what do
oh,
experienced professionals risk losing if they sit this one out?
first thing is that, like I shall be precise on this, that signal detection where previously manual means manually we used to check volumes of documented work to check for that particular signal about adverse event will check. Now the AI, that is the agentic AI agents will communicate among themselves, or they will themselves find it within minutes, I will say, if there is a specific signal issue there, and then that can be automatically reverted back to the regulatory authorities, which will certainly have an enhancement in terms of time, money, etc. Second thing is that the triage part and data entry part in any medical device case processing, or uh, even in PV, will get automated by AI. That is for definite. Certain medical decisions cannot be automated by AI, because AI, every chance is there that AI works on algorithm and they will have a bias. They will have a bias on that. So if they start casting the same bias for every case, then it will be a totally different, I mean, it will be total chaos. In this case, of course, professionals like us with domain experience will have to have more better judgment over what the AI brings out. Third is that uh, in terms of even in medical device, even in terms of diagnostics part also, that also is being slowly automated, but ultimately there will be oversight from doctors, radiologists, etc., who will check on the films and who will look into it to be sure that everything is done. May not be for every 100 cases which the device does, a 10% quality check will always be done ultimately. So ultimately, what I mean to say is that AI will help you, but it will replace you. It will help you to find out the blind spots which are there. And then you can work on those blind spots with the help of AI or without the help of AI to get things done much more proper. Can you repeat the second part of your question again?
Yes, absolutely. So, my second part was what do experienced professional risk losing if they sit this one out?
So basically, the experienced professional will certainly first thing is that the super managers, a person with AI, of course, will have two things. First, in a professional environment, importance will be given much more to them. They will have a better outlook. They will have better they will have a better remuneration of, it is found that almost 20 to 25% extra remuneration with persons with AI. Third thing is that the fear of sitting out. That is that if everything is run on AI now, just mundane tasks manually, which is done by manager, this task will slowly get automated. So if instead of being a manager, one has to be an AI manager with a domain specification, so that the person can stand out among the crowd, among everybody. Thank you.
Rightly said, Mr. Saurav. So, on that note, let us switch gears for a while. A few quick questions, short answers. Sure. Pharmacovigilance in one word. Is it guardian? Is it detective or translator?
First word I did not hear properly. I'm not hearing
Guardian,
properly.
guardian.
Guardian. It is a guardian. Pharmacovigilance in one word is a guardian. There cannot be
Okay.
any second thoughts to this.
Okay. Next one, the most underrated skill in a project manager, patience or clarity?
Clarity. Clarity is the most underrated skill, because
Thank you.
patience will be there, but without clarity you cannot move the project forward.
Absolutely. My next one to you. AI will replace paperwork in pharma. True or false?
Partially, partially. A certain amount paperwork like the mundane tasks, data entry part will be replaced. The rest of the part, it will be replaced, but it will not be a one-off situation. It will take its own time.
Okay. One city that is felt most like home to you, Bangalore, Kolkata, or somewhere else entirely.
My best city is Bangalore. Of course, Kolkata is also where I was born, but Bangalore is most my best city, I will say.
All right. If you had one extra, if you had an extra 2 hours every evening, you would spend them learning, teaching, or genuinely doing nothing.
I will spend it in teaching because I believe teaching helps you in learning. As you teach, you will automatically learn. I have learned it that way, that once I start teaching people the same thing which I learned, that makes me more clearer and more clarity sets in.
All right. So that was all for the quick fire round, and that was honest and quick. Great, Mr. Saurav. Moving forward, I want to take us somewhere real for this next question. Not a hypothetical, but something the world actually watched unfold. Uh, Talking about 21, 22, Philips had to recall millions of sleep apnea machines globally because of foam defect. And reporting later suggested that internal signals about the problem had existed for years before the recall happened. You have spent your career in medical devices and pharmacovigilance. Now, when a story like that breaks, what does it tell you about what actually goes wrong inside a company? Not in the headlines, but in the quiet culture underneath.
So basically, I will say 1 or 2 to 3 points on this, which comes to my mind. First thing, that's working in silos. One department the engineering department may have that data that this issue is coming up, but they are not able to push. But since they have some issues with the other departments, they are not able to push it to the marketing or any other, or the vigilance or any other department. So this thing will stay in them only. I think this is one of the reason in Philips, because they already knew it, but they did not push it. Second thing is that uh, well, taking this issue that particles, this particles, this was normalized. Basically, this was normalized. Means, okay, this is there. The next one will not be there. So we don't point this thing out. We don't point this thing out. So this was a normalization of deviance, you can say. The deviation was there, but they not and but it was normalized. So these people might not have pushed everything out. And third thing is that there is a difference between listening and reporting. Reporting here, in this case, might be it was reported, a mail was sent and it was reported, but ultimately the report got lost in the mundane channels anywhere. No one looked at it, and even if they looked at it, also they must have just ignored it. Then ignored it. Instead of this, if they would have listened, a person would have personally called up and listened to him, called up or called a meeting, and where a listening was done, documentation was done, things would have moved much better. Fourth thing is that there is this chill effect. Like, generally, I have seen that managers discourage bad report. Manager chill effect, which you call the managers discourage. There is a systemic bottleneck here. There is a systemic bottleneck here, but that systemic bottleneck, no one is willing to, even up to the level of the board, the senior management, no one is willing to accept that, because it can cause commercial loss to them. So here again, the same point comes up, that the commercial versus quality. Commercial quality has to be paramount. You cannot have quality versus commercial here, because you are dealing with patients' lives here. This, with a 0.03% of reporting, I think what happened, one more thing which happened was hardly there was a 0.03% errors in the mask, but that 0.03% amounts to, when you sell millions of masks, it amounts to quite a large number of patients getting affected. And so there has to be some, so there has to be a chilling effect where the managers did not report because they were afraid that this this issue was there. So the only way to deal with, I believe, to deal with this is that the quality has to be paramount. Reporting has to be encouraged. Quality reporting has to be encouraged. And of course, there is this issue about hazard versus harm. Hazard versus harm. In a device case, we look at the hazard, but we don't look at the harm. Until the hazard converts into harm. In harm involves the clinical aspect where the patient is harmed, and hazard is okay. These particles. So very likely company took the hazard part but did not get into the harm part, which resulted in this. So ultimately what I meant to say is that this quality aspect has to be dealt with very clearly. Escalation has to be done, needs to be done at the proper level, and feedback has to be encouraged, and you cannot just banish a person who reports. Killing the messenger doesn't work here. Thank you.
Absolutely. And, Mr. Saurabh, you said something that is going to stay with me forever. The difference between a reporting system and a listening system. Most organizations have the first, very few have the second. And as Phillips learned, the cost of that gap runs into billions and, more importantly, into real lives. All right. So, Mr. Saurabh, before we close, I want to talk about something personal. You are a valued member of Directors Institute, World Council of Directors. What made you reach out to Directors Institute in the first place? And what has that
So,
experience given you
yeah,
that career alone could not?
so basically, I did a lot of research on Director Institute. I did a lot of research on many other institutes also. And what stood out for me was that Director Institute will help me bridge the gap between a manager and a governance. There is a big gap between governance and a manager. As a project manager, we are executing the project. We are not, what do you mean to say? Governing the project. The governance part is done by the director level people or CEO level people there. And we report it to them. But as in governance, we have to understand that we are not the executor. We'll have to give them the guidance to execute. We can help them by asking questions properly so that they don't fail. They put it in a proper channel and then they put it properly. And if there is any issues coming up, any bottlenecks, any blind spots which come up, we should be the first person who find it. So these all things Director Institute, I believed, will help me to iron out. Second thing is that in terms of teaching, they have a lot of tie-ups with some foreign universities, like university means Oxford University, Wolf University, etc. So I liked that part, which will give me a global prevalence here. Third thing is that the placement part. The Director Institute is a very good placement record from what I heard. So that all these things put together, I decided to choose Director Institute.
Great to hear that, Mrs. Saurabh. You came into governance through the operational door, delivery, quality, people, crisis management. And honestly, that is exactly the kind of voice boards need more of. Uh, Not theory, but people who have watched things break and fix from the inside. That experience is a different kind of authority altogether. Uh, Great. So let me tell you, Mr. Saurabh, what I'm taking away from this conversation is something unusual. You started your career listening, doctor after doctor, case after case, and somewhere along the way, you became the person that teams of 500 plus now listen to. That arc from receiving words to shaping them is genuinely rare. And I can hear it in how you talk about everything: quality, patience, AI, governance. You do not talk at the work, you talk from inside it. That is a different kind of a leader. So thank you so much for joining us and sharing your insights with us today.
It was my pleasure attending this podcast. Thank you very much.
And to our listeners, whether you are a seasoned executive or someone just beginning your journey, Mr. Saurav's story is a reminder that the quiet years are never wasted. The roles nobody celebrated are often the ones that build the judgment everybody eventually needs. Thank you for tuning into FaceTime with Leaders, powered by Directors Institute, World Council of Directors. I'm your host, Sunny Pancholi, signing off for now. Until next time, stay curious, keep listening, and most importantly, lead with care. Thank you so much.
Thanks. Thank you.